today's topic is cutaneous tuberculosis. The epidemiology is it occurs worldwide and incidence of different forms varies globally. Around 30 types of Mycobacterium tuberculosis are there. Mycobacterium are there. In India, around 2% of all OPD patients in 1950s and 1960s were of tuberculosis, but in 1980 it reduced to 0.1% due to the availability of effective drugs and improvement in the living standards. So, scrofuloderma is most common type of cutaneous tuberculosis in children, while lupus vulgaris is the commonest type of cutaneous TB in adults. And also in worldwide, scrofuloderma is the most common. Resurgence in tuberculosis and consequently in cutaneous tuberculosis due to the HIV pandemic, resistant strains of Mycobacterium tuberculosis, use of immunosuppressive therapy, ease of global travel and migration, poverty and malnutrition. So these are the predisposing factors. The mycobacteria are 0.2 to 0.5 to 2 micrometer in size. They are non-motile, non-capsulated, non-spore forming, gram-positive bacilli. They characteristically retain carbonfuran dye when treated with the dilute mineral acid or absolute alcohol. That's why they are termed as acid-fast bacilli. This property of acid-fast alcohol fastness is used in the Gill-Nielsen method of staining, that is Zn staining, where the mycobacteria appear as a pink stained rods lying singly or in groups in blue background. So Mycobacterium tuberculosis is an obligate aerobe but can survive in the partial anaerobic state also. So this feature make it as an obligate parasite in the human body also. This Mycobacterium tuberculosis, Mycobacterium bovis, under certain conditions cause cutaneous TB. BCG, an attenuated strain of Mycobacterium bovis. Mycobacterium tuberculosis and bovis cause identical skin manifestation in humans. In HIV-infected individual, even atypical saprophytic strains of Mycobacterium may cause infection and forms the bizarre types of disease. So this cutaneous tuberculosis, spectrum of cutaneous changes induced by Mycobacterium tuberculosis, it depends on the route of infection and also on the immunological status of the host. And mere presence of mycobacteria in the skin does not lead to the clinical disease. There should be any abrasion or breach in the continuity of the skin to spread inside the body. So the route may be either exogenous, endogenous, or due to the autoinoculation. Exogenous spread will be from external source through breach in the skin at the site of trauma. Endogenous will be through contiguous involvement of skin, through lymphatic spread, or through hematogenous dissemination. And third one is by autoinoculation. So this is modified form classification by exogenous source is called inoculation tuberculosis. Endogenous is secondary tuberculosis. Hematogenous spread through blood and eruptive tuberculosis, that is called tuberculitis. Inoculation tuberculosis through exogenous source may form tubercular chancre. Warty tuberculosis, that appearance will be like verruca, so it is called verrucosa cutis. And third one is lupus vulgaris, that is most common type. Secondary tuberculosis through endogenous source by contiguous spread, it causes scrofuloderma over the skin along with the enlargement of lymph nodes. And by autoinoculation over the orifices, it forms orificial tuberculosis. Hematogenous tuberculosis causes acute miliary tuberculosis, lupus vulgaris in suppression, and tuberculous gamma. So initially a form subcutaneous nodule that is fixed to the overlying skin, that is called cold abscess formation. It may cause secondary ulceration or sinus tract formation beneath the skin. So this ulcer has an undermined edges and granulating floor. and underlying sinus formation up to the lymph node. Here we can see the involvement of supraclavicular or submandibular lymph nodes, scrofuloderma, involvement of skin along with the underlying lymph node or any tubercular focus in the bone. Ulceration and suppuration of the underlying lymphadenopathy, cervical lymphadenopathy with ulceration, we can see in the second photograph. Third one is the scrofuloderma affecting the axilla and involvement of axillary lymphadenopathy with discharging sinuses. So it is characterized by the granulomatous or ulcerative or suppurative skin lesion along with the lymphadenopathy that may form scarring or maybe cause the formation of discharging sinuses. These numerous sinus tracts and fistula develop over a period of several months, and spontaneous healing may occur with puckered and cord-like scar may form. This scar tract characteristically breeds the area of ulceration or even the normal skin. Here we can see the formation of bridging scar. This bridged scar resulting due to the suppuration and healing with fibrosis occurring in the matted tuberculous lymph nodes. So axillary lymph node are involved, forming the bridging scars after healing.